Hi there, my name is Arsalan Zamir. I'm a GP with an interest in sport and exercise medicine. Today I'll be talking you through the shoulder joint examination with the consent of our kind volunteer. Thank you very much. Before we actually get into the examination itself, it's very important that we've actually taken an adequate history beforehand, and that is to make sure that we've got a good background to guide us through the shoulder examination in terms of mechanisms and possible signs and symptoms that we might be looking for. Before we focus in on the shoulder joint itself, what I'd like to do is assess the kinetic chain viability as well as core stability. And the way we're going to do that is through a few simple maneuvers. So if you could kindly please put your chin to the chest for us, chin to the ceiling, all the way up, excellent. Chin to your right shoulder, chin to the left shoulder, ear to the right shoulder, and ear to the left shoulder. So what we're looking for is movement of the cervical spine there. Did you have any discomfort during that procedure? Excellent. So that gives us a good idea. There's a good range of movement there. Then what I want to try and do is check the head and neck area. So I'm going to just press on the head and neck region. Just let me know if there's any discomfort at all. Just pressing down axially on the head. Any pain or discomfort there? Any pain down your arms? Just feeling down the spinous processes. Any discomfort there at all? Any tingling in your arms at all? No. Excellent. We're going to move on to core stability now. And a simple screening tool for the core stability is to do the one leg squat. Now, I'd like you to just stand on one leg for me, please, and squat down to 90 degrees. Excellent. Back up again, and the other side. Excellent. Back up again. So what we're looking for is rotation at the knee, differential in height at the pelvic region, and difficulty in the upper body in actually managing to do that maneuver. So actually the core stability seems pretty reasonable there. We'll now move on to inspection. So from the front area, we're looking for the whole chest area. We're looking for elevation of the shoulders, the trapezius, looking at the clavicle region, and lower down the pectoralis major, making sure there's no asymmetry that we can pick up on. So it looks perfectly fine there. The other things that we also can look at is any scars, any bruises, any differential in the two sides in terms of appearance generally. So that's all fine. So I'd like to just touch some of the areas of the front chest. So we'll start with the sternoclavicular joint and just palpate across the clavicle, right across to the AC joint, so the acromioclavicular joint. Is there any tenderness there at all? Excellent. Just moving down a little bit, feel the coracoid process. And just underneath the thumb, we've got the biceps tendon here. Just lift up the arm, abduct it a little bit. We've got the pectoralis tendon there as well, which is fine. Good, so nothing there at all. Now if we just turn you around, facing the other way, please. Brilliant. Similarly, from the back, from the posterior aspect, we're looking for the height of the shoulders, making sure that they're equal. Looking for any atrophy, any wasting of the muscles. So that's in the superior aspect that might indicate a supraspinatus issue. We've got the infraspinatus region just there. And then feeling across from the acromion, across the superior aspect, the border of the scapula, and then down the medial border as well. Just feeling there. The other thing we want to do is just check to see there's no winging and that the scapular border to spinous process, the midline, is equal, which it is in this case. While we've got our subject facing the other way, probably a good idea to check for scapular dyskinesia here. And that can be quite prominent in people that are using the shoulders quite a bit. So to screen for scapular dyskinesia, what we'd like to do is just shrug your shoulders upwards, please. Excellent. Downwards, forwards. Shrug your shoulders forwards, please. Forwards. That's backwards, forwards. Excellent. Good. And hands on your hips, please. Shrug your shoulders upwards, downwards, forwards. That's backwards, forwards. Excellent. Very good. Step across to the wall just to do another maneuver for scapular dyskinesia. So we're going to ask you just to put your hands on the wall and just do a press up for us on the wall. So if you push against the wall and back again. Excellent. We do that once again. I'm just going to put some resistance to the press up, back again. And again, we're looking for any asymmetry there. Brilliant. Excellent. Now we'll just turn around again, facing the camera. Brilliant. Now we're going to check the range of movement. Now with range of movement, the first thing to do is arms by your side, and in front of you, taking them forward, straight up, as far as you can go, right up, excellent, back down again, so that was 180 degrees. By your side, and taking your arms from your side upwards, straight up again, so that's 180 degrees as well. Brilliant. Back down again. Then what we're going to do is we're going to check for external and internal rotation. So arms up like this for us. Brilliant. Backwards, forwards, up. Brilliant. Excellent. Excellent, by your sides. We're going to now isolate the glenohumeral joint because in those manoeuvres what we've got is the scapula, scapularis playing a role there as well. So by placing a hand on the scapula, I'm going to do those similar manoeuvres by myself. So with forward flexion, just as you feel the scapula move, you stop, so that's pretty good. And then abduction, excellent. And then what? Internal rotation and external rotation. Brilliant, excellent, by your side again. All right, now, just take a seat for us. You take a seat on the couch. Now what we're going to do is we'll focus into specific areas of the shoulder joint and use some special tests to see whether we can pick up any abnormalities. The first thing we're going to do is check the AC joint. So as we said, the AC joint coming across from the clavicle and up to the AC area here. Any tenderness there at all? We can check for inferior distraction to see if there's a sulcus there or a valley, and also take the arm across, called a crossover test, to see if there's any tenderness there at the AC joint, which there isn't. That's excellent. Arm on your side. Move on to the biceps down, and we're going to check to see whether there's any tendinopathy signs that are present. The first and most easy test probably is the speeds test. So arms straight out for us, please. Yes, arm. Excellent. I'd like you to raise your arm to the ceiling for us. Up, 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 up. Excellent. Any tenderness here? Excellent. Then what we're going to do is the uppercut test, which is one of my favorites actually. So the uppercut test is making an uppercut formation and up to the ceiling for us. Brilliant. And down again. Any discomfort there as well? Brilliant. Now Jurgensen's test. So Jurgensen's test with the elbow by the side. What I'd like you to do is open your palm for us. Open the palm. Excellent. Any discomfort there at all? No. Brilliant. Excellent. Relax. Jurgensen's test, interestingly, forms one of three components for Kuhn's protocol. The Kuhn's protocol is a very useful protocol, evidence-based, that we use to exclude a slap tear, which is a superior labral anterior-posterior tear. Now, Jurgensen's, as I said, is one of those components. The second component we can do is actually just an inferior distraction, just to see if there's a sulcus or a valley that forms just below the acromion, just there. The other test that we're going to do is lifting up the arm to abduction, just putting some actual inferior distraction there. Any discomfort there at all? Brilliant. So those three tests, the Jurgensen's, the inferior sulcus with distraction, and the apprehension test there, any of those that are positive makes it positive as a chance for a slap tear. The more of those that are positive, the greater the chance of a slap tear. And actually, if there are any positive signs, we will probably be considering an MRI scan. There are a couple of tests that we can do to see whether we can pick up a slap tear as well. One is O'Brien's test. So that is adduction of the arm, okay? And what we're going to do is turn the arm over, like so, and upwards. If you raise your arm upwards, brilliant. Any discomfort there at all? No. And then we're just going to, as an adjunctive test to that, is a slapprehension test. So turn the arm over. If you raise your arm upwards, if, let's say, there was discomfort with the O'Brien's, this we would expect to relieve that discomfort. Brilliant. On your side. Now, moving on to the rotator cuff, composed of four muscles. So infraspinatus and teres minor. So we can check for that quite easily. So arms by your side, okay, by your side, and I want you to take them outwards. So resisted external rotation. That's brilliant. What we want to try and do then is do resisted internal rotation. So you just push your hands downwards. Excellent. So that's checking for subscapularis and isolated pectoralis major. Then moving on to supraspinatus specifically, and the test that we want to try and check for impingement is the empty can test. So if we raise the arm up, turn the arm over as if we're holding an empty can, and raise the arm upwards to the ceiling. Brilliant. Any discomfort there at all? Now if there's discomfort there, it can indicate a tendinopathy or an impingement, and actually if the arm goes straight down, it might even indicate a supraspinatus complete tear or rupture. There are a couple of other tests that we can use for impingement. The first is by placing the hand just below the acromion, and we're going to raise this up with forward flexion. This is called Neer's test. So raising it up, if there's any discomfort there, any discomfort at all, then that would indicate a positive Neer's test. The Hawkins test, very easy, we'll just bring it up to abduction, and if we just bring it into internal rotation, any discomfort there at all? No. Excellent. By your side again. Brilliant. Finally, we'll move on to check if there's any shoulder instability. Before checking for shoulder instability specifically, we can screen for instability and laxity in the rest of the body. So this is quite a common issue, shoulder instability, with people that are using the shoulder repetitively, especially with overhead use and recurrent dislocations. So I'm just going to bend your fingers backwards, just to see if there's any hyperextension there, which there isn't. You turn the elbow over, just check from underneath to see if there's any hyperextension there, which there isn't. Excellent. Now, shoulder instability, a couple of things that we can do here for shoulder instability. One is the inferior distraction, again checking for a sulcus or a valley, so if there's any AC laxity there, or AC discontinuity there, we'll see a sulcus or a valley sign. And then the other thing that we can do, just sitting by the side, placing a hand on the scapula, stabilizing that, get a hold of the humeral head, and just distracting it posteriorly and anteriorly, and just checking to see whether that causes any discomfort. Any discomfort there at all? No. Thank you very much indeed. So that concludes our examination of the shoulder joint.